Okay, coronary artery disease. Areas of partial or complete blockage of coronary circulation. Cardiac muscle cells need a constant supply of oxygen and nutrients. Reduction in blood flow to the heart muscles reduces cardiac performance. Coronary ischemia. Reduced circulatory supply for partial or complete blockage of coronary arteries. This picture is showing you a good heart with good circulation versus an occluded circulation, blood flow. Coronary artery disease. Let me get this cursor out of the way here. Coronary artery disease, usual cause is formation of a fatty deposit or atherosclerotic plaque in the wall of a coronary vessel. The plaque, or an associated thrombus clot, narrows the passageway and reduces blood flow. While we're talking about the thrombus or clot, that's stationary. If that thrombus breaks free and starts moving, it becomes an embolus. That's what we describe as an embolus. A spasm in a smooth muscle or vessel wall can further decrease or stop the blood flow. Here we're seeing a picture of a normal artery versus an artery that has some atherosclerotic plaquing. In the cross section, we can see how it narrows the size of the artery. Okay. Angina pectoris, commonly one of the first symptoms of CAD. A temporary ischemia develops when the workload of the heart increases. Individuals may feel comfortable at rest. Exertion or emotional stress can produce sensations of pressure, chest constriction, and pain. Pain may radiate from the sternal area to the arms, back, and neck. Myocardial infarction, or an MI, heart attack. Part of the coronary circulation becomes blocked. Cardiac muscle cells die from lack of oxygen. The death of the affected tissue creates a non-functional area known as an infarct. Most commonly results from severe CAD. Coronary thrombus. Thrombus formation at the plaque, most common cause of the MI. Here we see a magnified area showing representation of an occluded coronary artery, and below that is where we would find the tissue that is damaged as it's not receiving its oxygen. Myocardial infarction. Consequences depend on site and nature of the circulatory blockage. If near the start of one of the coronary arteries, the damage will be widespread and the heart may stop beating. If blockage involves the small arterial branch, the individual may survive the immediate crisis, but may have complications such as reduced contractility and cardiac arrhythmias. Continuing with myocardial infarction, causes intense persistent pain, even at rest. Pain is not always felt, may go undiagnosed and untreated, often diagnosed with an ECG and blood studies. Damaged myocardial cells release enzymes into the circulation, cardiac troponin T, cardiac troponin I, and a form of creatinine phosphokinase. And if you've had a heart attack, they can see this in your blood work. Treatment of CAD and myocardial infarctions. About 25% of myocardial infarct patients die before obtaining medical assistance. 65% of myocardial infarction deaths among people under the age of 50 occur within an hour. Risk factor modifications. Stop smoking. Stop vaping. Treat high blood pressure. Adjust diet to lower cholesterol and promote weight loss. Reduce stress. Increase physical activity. So you might switch your remote from your right hand to your left hand. Drug treatments are used to reduce coagulation, block sympathetic stimulation, cause vasodilation, block calcium ion movement into the muscle cells, relieve pain, and help dissolve clots. Non-invasive surgery, atherectomy. A long, slender catheter is inserted into the coronary artery to remove plaque. Balloon angioplasty. The tip of a catheter contains an inflatable balloon. The inflated balloon presses plaque against the vessel walls. Plaque commonly redevelops. A stent may be inserted to hold a vessel open. Coronary artery bypass graft. A small section of another vessel is removed, used to create a detour around obstructed portion of the coronary artery, which reminds me, when we're young and we have a problem with an artery, it gets obstructed, the body has the ability to grow another one right around it and continue the blood supply. This changes as we get older and we don't have the ability to make new blood cells like that, or blood vessels, excuse me. Up to 4 coronary arteries can be rerouted during a single operation, or you may say rerouted. A single, double, triple, or quadruple coronary bypasses. Okay, heartbeat, a single cardiac contraction. Heartbeat, a single cardiac contraction. All heart chambers contract in a series. First the atria, then the ventricles. First the atria, then the ventricles. 2 types of cardiac muscle cells. Autorhythmic cells control and coordinate heartbeat. Contractile cells produce contractions that propel the blood. Conducting system consists of specialized cardiac muscle cells. Initiate and distribute electrical impulses that stimulate contraction. Autorhythmicity. Cardiac muscle tissues or tissue contracts without neural or hormonal stimulation. Components of the conducting system, and let me go here and just show you what we're going to be talking about. We have the SA node, the sinoatrial node here, the AV node, the AV bundle or the bundle of His, the bundle branches, and then the Purkinje, or the bundle branches, and then the Purkinje fibers. This is the flow of the electrical conducting system of the heart. So, components of the conducting system. We have pacemaker cells, which are cells that are pulsating. The pacemaker cells are found in the sinoatrial or SA node, which is in the wall of the right atrium. The atrioventricular AV node at the junction between the atria and the ventricles. Conducting cells are found in the internodal pathways of the atria. The atrioventricular AV bundle, and what we're talking about now is the flow. The AV bundle to the bundle branches to the Purkinje fibers in the ventricles. These are the internodal pathways. So SA node to the AV node, and then the internodal pathways are the bundle branches, and the Purkinje fibers in the ventricles. We talked about muscles before, and nerves, and how we achieved an action potential. We're going to discuss that similarly. It's not that much different. There are some differences, but I want to refresh you as far as the action potential. We talked about a resting membrane potential of a negative 70 millivolts, which needed to depolarize, which sodium would rush in to depolarize. And then we had the action potential, and then the potassium would leave the cell, and we would repolarize. And we had hyperpolarization, and then the ATP came into the area and started sodium potassium pump to bring the balance back and to get us back to a resting membrane potential. That was just a quick review there, and that's what we're going to be discussing here is the action potential of the heart. The pacemaker potential gradually depolarization of the pacemaker cells. Do not have a stable resting membrane potential. Rate of spontaneous depolarization. The SA node is 60 to 100 action potentials per minute. The AV node, 40 to 60 action potentials per minute. And just as a note, you remember we talked about the absolute refractory period, which during that time we couldn't have another action potential because the chemistry needed to redevelop or rediffuse in the area. There wasn't enough chemistry to fire it off. So what it's saying here is we've got 60 to 100 action potentials per minute in the SA node, 40 to 60 action potentials per minute in the AV node. The SA node depolarizes first, establishing sinus rhythm. The parasympathetic stimulation slows the heart. Okay, again, we already walked through this. We'll do it again. The SA node, which fires off to the AV node, which goes down the bundle, AV bundle or bundle of His, to the bundle branches, which then carry the stimulation around the ventricles by way of the Purkinje fibers. And what we're seeing here are changes in the membrane potential of the pacemaker cells in the SA node that is establishing a heart rate of 72 beats per minute. Note the pacemaker potential, a gradual spontaneous depolarization. So what we have here is we have millivolts versus time on our scale here. We're depolarizing, repolarizing, we hyperpolarized. We need to come back, and it's a gradual process. We'll see as we go through here a little further that this process, there's a slight delay in, well, it's a longer process than it was with skeletal muscle, and that's due to the calcium uptake. Impulse conduction through the heart. The SA node activity and atrial activation begin. Stimulus spreads across the atrium, reaches the AV node. The impulse is delayed 100 milliseconds at the AV node. Atrial contraction begins. Again, what we're seeing here is simply what it's saying. We're viewing it and we're talking about what's happening when we look at an ECG tracing. So on number 1, we have the SA node activity and the atrial activation begin. And we see that here. And number 2, the stimulus spreads across the atrial surfaces and reaches the AV node. So we're spreading across both atria. Notice it's not just the right one. We're spreading across both atria, which creates the P wave, atrial depolarization. The P wave, atrial depolarization. And what we're going to see here is we're going to see the P, Q, R, S, and T. And not only are we interested in the peaks, but the spaces between the peaks tell a story too. So the story of the P is going to tell us is that is where the atria is depolarizing. And then we have the space just after depolarization. The PR interval, conduction through the AV node and the AV bundle. So we've gone from the SA node to the AV node, and now we're going through the bundle, or the bundle of His. The impulse travels in the AV bundle to the left and right bundle branches in the interventricular septum to the Purkinje fibers. The papillary muscles via moderator band. Purkinje fibers distribute impulse to the ventricular myocardium. The atrial contraction is completed. Ventricular contraction begins. So, as we saw here, the P, the interval, and now we're at Q. The impulse travels along the interventricular septum within the AV bundle, and the bundle branches to the Purkinje fibers and the moderator band and the papillary muscles of the right ventricle. Q wave is the beginning of ventricular depolarization. The beginning of ventricular depolarization. P was atrial depolarization. The QRS complex. QRS complex is the completion of ventricular depolarization. The completion. The impulse is distributed by Purkinje fibers and relayed throughout the ventricular myocardium. Atrial contraction is completed and ventricular contraction begins. Disturbances in heart rhythm. Bradycardia, abnormally slow heart rate. Tachycardia, abnormal fast heart rate. Ectopic pacemaker, abnormal cells generate high rate of action potentials. Bypasses the conducting system, disrupts timing of ventricular contractions. Electrocardiogram, ECG or EKG, a recording of electrical events in the heart obtained by placing electrodes at specific locations on the body surface. Abnormal patterns are used to diagnose damage. Features in the ECG, the P wave, which we looked at, depolarization of the atria. QRS complex, depolarization of the ventricles. The ventricles begin contracting shortly after the R wave. And the T wave, the repolarization of the ventricles. The time intervals between what we're talking about. The P and R interval from start of atrial depolarization to the start of the QRS complex. The Q to T interval is the time required for the ventricles to undergo a single cycle of depolarization and repolarization. Q to T interval. Let's go back to the Q to T interval. So we're talking about this interval right here. Time required for the ventricles to undergo a single cycle of depolarization and repolarization. And this is showing a picture of the electrode placement for recording standard ECG. We've kind of seen this already. We talked about the P, QRST, and the intervals associated with them. Some more information here. Some problems associated with the findings. Cardiac contractile cells form bulk of the atrial and ventricle walls, receive stimulus from Purkinje fibers. Resting membrane potential of the ventricle cell is about negative 90 millivolts, where the atrial cell is about negative 80 millivolts for the resting membrane potential. And we saw that in when we were talking about action potential with the nerves, we're usually looking at a negative 70 nerves and muscles, millivolts. Intercalated discs. The cell of the heart is not one single long cell as it was. We could see that with the muscles. It's a combination of several of them working together. And in order for them to work together, it's kind of like a prayer chain where you have to hold hands and with someone else, and that's what they do, the heart muscles. They grab hold each other, and the area where you would be holding hands is considered to be the intercalated discs, which hold the cells together to one another. So the intercalated discs are an interconnected cardiac contractile cells. Membranes of adjacent cells are held together by desmosomes, linked by gap junctions. Transfer force of contraction from cell to cell. They propagate action potentials, which means the conduction system is going to be transferred from one cell to cell very quickly. And here we see several cardiac cells, cardiac contractile cells, and they're being held together with the intercalated discs that you see running up and down through here. And I think there should be another picture. There it is. Okay, so we see from Z-line, you remember we talked about the sarcomere, and within this, just for review, we've got the red, which is the actin, the purple, which is the myosin, Z-line to Z-line of the sarcomere. And what we're doing here is we're creating intercalated discs where we grab a hold of the different cells at the Z-lines to where they can hang on to each other. And we're creating, well, the desmosomes are holding these things together. Here, these dark lines that you can see, those are the intercalated discs, which when we're looking at skeletal muscle versus cardiac muscle, this is one of the distinguishing factors that we can see is the intercalated discs associated with cardiac muscle tissue. Characteristics of cardiac contractile cells, they're small, whereas skeletal muscle is very long. Single central nucleus, whereas skeletal muscle again was multinucleated. Branching interconnections between cells held together with intercalated discs. Now, as we talk about the action potential in the cardiac muscle, we have rapid depolarization, a massive influx of sodium through fast sodium channels. Plateau, we've got extracellular calcium enters cytosol through slow calcium channels. And what's ultimately going to happen is that calcium is going to stimulate the sarcoplasmic reticulum where we stored concentrations of calcium. But the extracellular calcium enters cytosol through slow calcium channels. And then we have repolarization where the potassium rushes out of the cell through slow potassium channels. So we want to depolarize fast, but our repolarization is slow because of the calcium channels and the slow potassium channels. Refractory period. The absolute refractory period, about 20 milliseconds. Cardiac contractile cells cannot respond. Yeah, we can't have another contraction until that's over and the chemistry has built itself up again. Relative refractory period, 50 milliseconds. Cells respond only to strong stimuli. Only to strong stimuli. Action potential is in a ventricular contractile cell, 250 to 300 milliseconds, 30 times longer than that in skeletal muscle fiber. Prevents summation and tetany. So here we can kind of get an idea of what's going on. Number one, we have rapid depolarization. Sodium rushes in, and it's very fast. Plateau, calcium enters. It's a slow process. Repolarization, as we're going down the graph, the bell curve. Potassium is slow. Closure of the slow potassium channels. And in the blue is the absolute refractory period, where we cannot have another action potential. In the relative refractory period here, we can if it's a heavy stimulation. Here we're seeing the comparison of skeletal muscle fiber versus cardiac muscle. Action potential, we're starting off at 85, negative 85 millivolts. We have the action, or depolarizing to the action potential, repolarizing here. It's a very fast process. Whereas with the heart, cardiac contractile cell, depolarization, we have a plateau, gradually depolarization as we come down this direction, and it's much longer as far as time, skeletal muscle versus cardiac muscle. We can see that with blue being the absolute refractory period in the skeletal muscle, nothing is taking place. We can't do it again here. But look at all this time that we cannot fire that action potential again in the cardiac muscle. Role of calcium ions in cardiac contractions. Extracellular calcium crosses the plasma membrane during the plateau phase, provides roughly 20% of the calcium required for contraction. Where's the other percentage? Okay, entry of extracellular calcium triggers release of the additional calcium from the sarcoplasmic reticulum, which again was the area that stored calcium reserves. Role of the calcium ions in cardiac contractions. Cardiac muscle tissue is very sensitive to extracellular calcium contractions. As slow calcium channels close, intracellular calcium is pumped back into the sarcoplasmic reticulum or out of the cell. Energy of the cardiac contractions. Aerobic energy from the mitochondrial breakdown of fatty acids and glucose. Oxygen is delivered by circulation. Cardiac contractile cells store oxygen in myoglobin. Cardiac cycle. Cardiac cycle. From the start of one heartbeat to the beginning of the next. One heartbeat to the beginning of the next. Start to start. Includes alternating periods of contraction and relaxation. The phases of the cardiac cycle. Within each chamber, we have systole and diastole. Systole is the contraction. Diastole references the relaxation.